Hello, everyone. I'm Traci Arieli, end-of-life doula and founder of Comforting Closure. Welcome to our podcast where we explore meaningful and often challenging aspects of end-of-life care. Making decisions about end-of-life options can be incredibly difficult for those who are terminally ill. It's a journey filled with emotional complexities and profound choices that affect everyone involved. Today, we're joined by a special guest, Morin, an expert in patient advocacy and an experienced guide in the journey of medical aid in dying. She's also the founder of LA Patient Advocates, an organization devoted to helping clients navigate our often overwhelming healthcare system. Together, we're going to discuss the sensitive and important topic of medical aid in dying. Karen, welcome and thank you so much for being here. Can you start off by telling us about yourself and how you came to create LA Patient Advocates?
Thank you. Thanks for having me here today also, and for the opportunity of talking about this subject with you. My background, I guess my first nursing job was on an AIDS unit. And when we were lucky enough to have the AIDS unit close as the epidemic slowed down, I moved over to oncology and bone marrow transplant at Cedars-Sinai, and later ended up working in home hospice. So I always worked in different variations of working with death and seriously ill patients. So that has always been my work. I also worked at a cancer support center here in the Valley in Los Angeles called WeSpark. I'm still on their board of directors now. And close the door. And so I got involved with medical aid in dying when I heard that they were working to get it passed in the legislature here in California. And so I became very active with Compassionate Choices. And when the law passed, I was involved with a number of small volunteer groups that help patients one-on-one, help them to find doctors who were supporting medical aid in dying, or maybe to find a hospice that was supporting it. So that was always sort of my calling, and people were contacting me. And at some point, I decided it was time to pull it all together, and developed LA Patient Advocates. I have a couple nurses that work with me now, and a number of doctors. And so we provide both advocacy, and I do a lot of consulting with hospices, providing a way to facilitate medical aid in dying for hospices that might not have doctors on board who are supporting medical aid in dying. So these patients are able to get it all the way through their care.
Great. Thank you. For our listeners who may not be familiar, could you explain what medical aid in dying is and who typically considers this option?
Well, by law, those who are using medical aid in dying have to have a terminal illness. They have to have 6 months or less to live. So medical aid in dying is it's in 10 states now in the United States have the law, and it is a procedure by someone who is terminally ill can request medication from their physician that would allow them to choose a timing and control their own death, and to prevent suffering at their choosing. So we find sometimes patients don't take the medication. They use it sort of as that backup to know. But more often than not, these are patients that are already in hospice. We find a great many are cancer patients, cardiac patients, renal patients, some neurological diseases, Parkinson's patients, or sometimes ALS patients. So a variety that you might think at any point that you might find in hospice. Sometimes patients aren't in hospice, but we encourage them to go on to hospice before they do take the medication.
Your role as a patient advocate um, I know you're a patient advocate and you're a nurse. How do you support and guide individuals considering medical aid and dying? What does that look like in a practical sense?
Well, patients may come to me in a number of different ways. They may come to me as looking for advocacy. Maybe they have a new diagnosis. With my background in oncology, I'll work with patients going through doctor appointments, walking them through, helping to decide about treatment options, and helping them to understand some of the questions that they're going to face and questions to ask their doctors. At that point, also, patients are often looking at their own end of life plans. How do they look, and sometimes how they change through an illness? We all may have certain ideas of what we want for end of life, but definitely as we go through an illness, those can often change. If someone is comes to me and they're looking for medical aid in dying, maybe they're also at the terminal part of their disease, then we'll look at are they already in hospice? Have they approached their doctor already about medical aid in dying? Oftentimes they come to me and they have already asked their doctors and now they don't know what to do. So sometimes we'll have them go to a hospice that may support them. They may have medical directors on board. The process itself involves seeing both a prescribing doctor and a consulting doctor, a doctor who confirms the diagnosis, confirms that the patient is mentally competent to make a decision. Many times these patients are making decisions about surgery and chemotherapy and a number of other treatment options. And now they're faced with making a decision about end of life. And sometimes their competency can be called into question, especially with neuro diseases or brain tumors and all. So we go through that procedure with them. Set up telemedicine calls as opposed to having to go visit the doctor. We get medical records and set these up for them so that they can go through the process as quickly as possible if necessary. Usually it can take the law. Most of the laws now are 48 hours between the first and the second. Some states are still 15 days or 2 weeks between the first doctor and the second. We had that in California for a while, and we were able to get it changed. We lost so many patients who were so sick and at the very end of their disease, and then they were trying to go to different doctor visits, get evaluated, and then wait 2 weeks and go back. And it can be very, very hard on the patient and the family. So usually we say it'll take 3 to 5 days to go through the whole process. But if we need to, I have wonderful doctors who work with me, and we can get them on the phone if we need to and do telemedicine calls. And then once that procedure is finished with the physicians and they've been cleared, then the prescription goes to the pharmacy. And then they have up to 6 months to take the medication if they decide to take it. So then it's about deciding. We go through the process, what it's going to be like when they take the medication, if they want family around, and then they can start to set up the procedure it's lovely when they can have family all around and everyone can get to say goodbye when they want to in the scenario that they would like.
So I just want to reflect on two different things. Now, what really struck me as great about your services, special about your services, is that a lot of times what happens is when a person requests medical aid in dying, even though that time between the first and the second doctor is 48 hours, sometimes the entire process to get the actual prescription is dragged out. And I know like Kaiser in California says it'll take them at least 3 weeks. And something that I found really impressive talking with you is you have the connections and the experience to really hurry that along so that a person isn't waiting the 2, 3, 4 weeks. As you said, it takes 3 to 5 days. And if there's a big rush, you could sometimes do that quicker. So I kudos to you and thank you because it's so important.
Well, definitely. Definitely when there are patients that are declining in front of your eyes and you want to be able to give them this comfort, this way of taking charge, taking autonomy over their life, their death, their suffering, and take control of the matter, being able to do this process as quickly as possible. We are lucky that we have some large institutions in our town, UCLA. Kaiser was always at the very forefront of end-of-life care, but it is a big institution and it's always stayed with this 15 days. You have to go from one procedure to the next to legal and get things signed off and then get the next signed off. And we've had the same experience with UCLA, and many times we'll have patients come to us and yes, they're in the UCLA system, but they just don't want to deal with all that comes with having to wait and go in and see a doctor and then wait for something else and get that appointment. At one time at Kaiser, if they couldn't, you wouldn't know until the day before if they would see the doctor, and then they'd have to wait for another 5 days. And you can imagine when someone is waiting to make this kind of decision, being able to be on top of it and help to get it accomplished as simply and as straightforward as possible can be very, very comforting. And many times, by the time the patients have come to me, they have been looking for a long time for this. Sometimes, they don't realize that it is a law in this state. People know about Oregon and Washington, and if somebody gets on the computer and Googles it and it's like, oh my goodness, it's legal here. It's legal in 10 states now, and they're actively working to get it passed in 8 other states right now. So when you find out that it is legal in your state, then you've got to find out, okay, how do I get it? It's one thing to have a law, but to find doctors and people that are knowledgeable about it and help you accomplish it. And, it's disconcerting to me as an RN that very often there are nurses that don't know about it. And patients ask their nurse, whether it's in the hospital or in a hospice, and they don't know. And I think we do have this ethical responsibility to know what the laws are. And even if it's not something that you would do or you believe in, we have to honor our patients' autonomy and agency over what they want and advocate for them. It's very, very important. So I get a lot of social workers that'll call me and say, oh, we have a patient that wants this, can you come in and help them? And then I would go to them, call, and then I start going through the whole process with them. But yes, very often they've been very, very frustrated up until that point and been told a lot of things that may not be true at all about the law. But any physician can write for medical aid in dying. Any physician can be a consulting physician. All the information is at the California Department of Public Health, and the same in any other state where it's legal. You can get the information there. It's a simple form to fill out, and there are a couple of agencies that would help new doctors if they haven't done it before to walk through it. There's an American Academy of Clinical Medical Aid in Dying Physicians. Compassion and Choices is another nonprofit that's very active in helping to support all end-of-life options for Americans and helping to work to make it better for everyone to get the option that they want at end of life.
You mentioned doctors, and a lot of doctors they they might know about it, but they don't know much about medical aid in dying. This isn't taught in a lot of medical schools, or it's taught very quickly. So there isn't a lot of knowledge sometimes. And in hospices also, some hospices are okay with medical aid in dying. Others do not want medical aid in dying to be performed by their doctors and nurses. How do people, from a perspective of talking to your doctor, what can people expect? How can they approach their doctors to talk about this? And also from a hospice perspective, if I'm going to hospice and I want this option, eventually, maybe not now, but eventually, what should I look for? What should I be asking that hospice?
Well, legally, right now in the state of California, when we changed the law to 48 hours, one of the rules that came into play was that all hospitals and hospices were supposed to have on their website what their policies were towards medical aid in dying. And I can tell you, it's going to be very interesting to go on them and find it. Now, you will find that if there is a hospice that does support it and actually facilitates it, that's going to be right on the very beginning of their website. And I can always suggest a number of hospices for that. I think we tend to have more down here in Southern California than Northern California. But you can also ask a hospice, what is your policy towards medical aid in dying? Now, again, the doctors and nurses aren't performing it. They're writing for the prescription. The patient has to be able to take it on their own. I can help mix it up, prepare the medication, and hand it to the patient. But the patient has to ingest it themselves. They have to, and we are using in California, we use the GI system. So it's not anything that we inject to the patient. It's something they either have to be able to drink, or some patients have a feeding tube. We can use a very large, big bolus syringe to have them bolus it into the feeding tube or into a little bag. They actually have to use their own hands to push the syringe. And we can also do it rectally with a tube that way. And again, they would use their own hands to push the syringe to have the medication go in. So there are certain types of conditions, patients with a lot of abdominal disease that may, and with a lot of nausea, they may use it rectally that way. So it is the patient, and we're assisting. We can be there to facilitate, but the patient is going to take the medication. But yeah, when you go back to doctors, remember that there's a lot of time where doctors in medical school were not trained about death and dying. Death, they were trained to treat and cure things, and that, death was something that happened. But death isn't, death is an outcome of a serious illness. We cannot always prevent that. And so for a long time, we'd have our new physicians would be coming on in July, and a lot of them had not been taught at all about death and dying and how to talk to families and how to deal with it. Now it's beginning to be a little bit more approach to medical school, and you'll see people are talking about it more. So they are somewhat better prepared. We have more palliative care doctors and then hospice doctors. So there is a lot more of it available. But if this is something that you are considering, you may want to talk to your doctor. Talk to your doctor ahead of time. Say that you've thought about it. You want to keep it there as an option at some point, so that when the time comes, that you can have some control over your death and dying and the timing of it. When someone is actively dying, to be able to control when they die and how they die, it can be very important, especially patients who have been sick for a long time and doing exactly as they've been told in terms of cancer treatment and chemo and one thing after another. Many times I'll get people who will call me going, I may do one more clinical trial, but after that, I think I'm done. Will you be there to help me then? And if their doctor says no, that they're not providing medical aid in dying. If they haven't done it, we can always recommend where they can get the information that will help them prescribe it. We've done that many times for doctors who are prescribing it for the first time. Or ask the doctor if they'll document it in your medical records that this is what you want, and if they can refer you to someone else. Sometimes they'll just end up referring you to a hospice, but it's amazing how many doctors don't know which hospices support medical aid in dying and which ones don't. I've had patients who are very emphatic that this is what they wanted now, and then okay, well, I'll refer you to a hospice, and refer them to a hospice that has nothing to do with medical aid in dying and won't even talk about it. They won't be in the room when it happens. And then it becomes, that much more difficult for the patient. So,
and even with hospices, I've worked with hospices supporting medical aid in dying, and there's sometimes a difference in what that support looks like. Some hospices don't want their nurses or doctors or social workers or volunteers to be in the room when the person self-administers, which personally is really heartbreaking to me. But there are other hospices that do allow that, which I'm a very big proponent, because I'm sure it's scary. It's not an easy thing to do, regardless where you are on the spectrum of pain or illness. It's scary. And so I personally want to be in the room supporting the person. But that's...
Yes, and what kind of message does that send to the patient? And it's been one of the issues, is that even if patients are asking these questions ahead of time, they're not always getting truthful answers. If you're asking the person that picks up the phone, do they really know what the policies are? And then when the time comes, they're finding out that that's not the case, or now they find out that no, the nurse has to be out in the car somewhere. And many times you've really developed a relationship with your nurse or your hospice worker, and want that support. So it is unfortunate that's one of the biggest things that I get, is that patients have not been told, we were told this, we were told we had to go to an ethics committee, we were told that nobody did this in Los Angeles. I mean, all kinds of things. And that's all we want. I give people a list of, okay, we're going to interview the hospice. This is what you want to ask. But if they're not getting truthful answers, I think some of this has evolved since the law has been in place here since 2016. And in the beginning, there was, all these, legal, I think people were afraid legally. There's never been, it's been over 30 years in Oregon, there's never been a lawsuit of any kind. And, again, these are patients that are already actively dying, that just want control over it. So, so I just don't quite understand some of the difficulties there. And I think I do a support group for families that have used medical aid in dying. And this often is one of the issues that comes up, is just the frustration that family members have gone through trying to get what the one thing that their family member was asking for: help me get this medical aid in dying. And then all the different problems that arose trying to get to that point. And I think sometimes that can really lay into some difficulty with the grieving process too. So it's getting a little bit better, because I think more people are asking for it than ever before. I think in the early years, even if patients were using it, they maybe didn't tell anyone else. Now remember, it doesn't affect wills or anything else. The diagnosis, or on the death certificate, it says the patient's underlying hospice diagnosis. So no one has to know what they did or how they came to die at that point. I usually say, well, the patient was on hospice, they were expected to die. But we do find that patients are calling and say, well, so-and-so's uncle did this, and that's what I want too. So people are hearing a little more. And I think the fact that hospices are getting more and more requests, maybe the policies haven't been changed, but definitely we are seeing more changes for sure.
Thank you. So I understand that you're willing to show us the medication used in medical aid in dying and explain how it's prepared. Could you walk us through the process and discuss the importance of understanding it?
Oh, sure. So a lot of people will think about, oh, it's an injection, or a lot of people equate, morphine. So and so, my mom went on hospice and they gave her a drip, and then that's how she died. And it's like, no, that's not really what the morphine does. The morphine helps to alleviate the pain, helps to ease the respiratory rate, but the respiratory rate tends to go down. And as the pain medication goes up, sometimes that respiratory rate is depressed, and then the patient will die. But it's not what was set out to do. It's just a cause of a patient who then is actively dying. So what is not, in the very beginning, we used Seconal capsules. We would open 100 capsules and get a toothpick and take the powder out. And with in the last 10 years, we've had some wonderful doctors that have really worked on protocols that really are just very effective to help a patient go to sleep. And you ask people, how do you want to die? You want to die in your sleep, and this definitely allows that. So the first thing we'll have a patient do is take some pre-medication. So there's 3 tablets, generally is what we use here, 3 different antiemetics and anti-secretion medication. So we'll have a patient take those and wait 45 minutes to an hour for those to take effect. And then towards the end of that, because the medication they're going to drink is very bitter, we'll often then have them take some sorbet or some popsicle, non-fatty, no ice cream or anything. We don't want any fatty foods. From the night before on, we're having patients not have any fatty foods and just have clear liquids. That just helps that digestive process. So now we're taking the popsicle, the mouth is good and cold. And most places the medication comes like this, sometimes a bigger bottle, but it's a number of different drugs combined in a powder form. So there's probably about 1.5 ounces, 2 ounces here. And then we add apple juice or water to that, 2 to 4 ounces. we've been using about 3 ounces of the liquid and shake that up so that it dissolves. Apple juice, because it really, really dissolves well with the apple juice. Sometimes we pour it into a big wide open glass to drink it out of, but a lot of times we end up putting a big milkshake straw into the bottle and drinking it straight from there. Then we're not transferring it back and forth. There's not a chance of spillage or anything. And I always tell my patients beforehand to think of it like a little like a thickened milkshake, maybe like Ensure or milkshake, and practice drinking that in about 2 minutes. How long would it take for you to drink, 3 ounces of a milkshake in 2 to 3 minutes? So we want them where they're going to be because we know they're going to fall asleep fairly quickly. We find that after drinking the medication, usually they fall asleep within 3 to 8 minutes. And they're going to fall into a deep sleep, then go into a coma. And once they're in the coma, they're not feeling anything. They're not, I always think hearing is the last to go, but it's very, very, very peaceful. So the medications are really meant to get the patient asleep right away. And then as we go down through that GI system and we get down into the villi of the intestines, each of the different medications are absorbed in different places, but then at some point, the respirations and the cardiac activity will stop. And that can take anywhere from an hour to 5 hours, usually a lot less than that, but it really depends on the patient, the age, other disease processes that are going on. So we like to, patients that have a lot of abdominal or colon or GI disease may take a little longer just because maybe they haven't been eating as much. Maybe there's been some other nausea, other factors going on. So there's a list of about 10 different factors that we look for just to help prepare the family. Again, the patient's going to be asleep, not feeling anything, but the family is often anxious and waiting for the death to come. So we like to prepare them. And, my background as an RN, to have that clinical knowledge of being able to help them know, what is normal, what sounds to expect, what breathing patterns are we looking for, things like that can be very comforting to the family. And by my being there and helping to do the mixing and the timing and all, patients can focus on the family and each other during this time also. So, and if we have to use any of the other methods, the feeding tube or the rectal, that's something that I've had a lot of experience with. And, you don't want to have a family member dealing with those kinds of issues. So, but we know that ahead of time and prepare them. So
thank you for sharing that. Many people don't know what to expect, so it's really helpful. Thank you. In order to participate in medical aid in dying, of course, you need to be able to make your own healthcare decisions. When a person has something like dementia, what options do they have?
Well, I try and tell people to plan ahead, to plan and talk about it. We Compassionate Choices, the nonprofit that I work with, has some really great resources on dementia, different stages of dementia, helping to understand that, and adding some addendums to your advance directives so that you can be very definitive with your family members or your healthcare advocate. Who is this person that's going to make decisions when you can't? Let them know what you want and what you don't want when you're not able to make those decisions. In MAID, you can add to them. Many times we sign some of these documents, we don't really understand what some of our options are and aren't, or that you could write some things in. But if I don't know, if I can't recognize anyone, or if I'm not wanting to eat anymore, there's different way. We have things called comfort feeding, or maybe we don't want to be fed. Or how about when someone gets a pneumonia later on, but they don't know anybody, and they're, many times I'll have patients' families call me and say, my mom said she never wanted to be this way. What do I do now? And try and go back and tell me, what has she told you? Okay, she told you that. What do you think that means? And patients can say that they don't want antibiotics if they were to get pneumonia later on. We can make sure that, and that doesn't mean, if we're not going to give a curative treatment, doesn't mean that we're not going to treat them at all. We're going to do comfort measures. There's a lot we can do to help keep them comfortable at end of life. This idea of feeding, very often we associate feeding with loving and nurturing. But when someone is beginning to actively die, the GI system is one of the first to start to slow down and shut down. So if we're giving more food at this point, we're only making our loved ones more uncomfortable. It's not going anywhere. The fluid is going on, but doesn't have anywhere to go. So,
but coming back to dementia, I know that, in order to have medical aid in dying, you need to be diagnosed with 6 months or less to live. And a lot of times, that's at the point where dementia is, the person is in the final stages of that, and they really aren't able to communicate very well. So in that case, then medical aid in dying is off the table, correct?
it's
And
off
they
the
need
table.
to look at something like voluntary stopping eating and drinking, or in follow.
Yeah.
Okay.
Yes, that would be one of the options, voluntary stopping of eating and drinking. And I think for a lot of people, that sounds just, like starvation, and sounds painful. And it sounds, there are a number of really great books and videos and information about it, especially if someone is towards the end of life now and in a decline. Very often they're not eating very much anyway. We try and tell patients we want patients to be on hospice then if we can get them on. Sometimes they may not qualify yet, but we can support them with humidifiers, moisturizing, and other ways, showing them love and attention by using massages and creams and music, so that family is nearby to support them and help them get through those first few days. And then as things start to shut down, that drive for food, and very important, is the fluids that we want to stop. And then they would eventually go into a coma. And there is some medications that we can give to support them and comfort them. And also I find we want to make sure that they are getting pain relief. Very often they'll say with dementia, well, they're not in pain, or they're not showing pain. Well, we know that as someone who has dementia, their face does not show pain. That neurologically, they're not able to express that. And, I know at my age, I'm getting up and out of bed and uncomfortable each morning too, that I can't imagine that someone who's in bed all the time or doesn't have similar aches and pains. So we want to make sure that the pain is being addressed, and any other symptoms there. But yes, they often can have infections that we want to make sure that we're offering pain relief, but not necessarily, maybe not antibiotics. And so you can document all this on your advance directive, what would happen if you got to this point. But it is difficult. I've had a number of patients who've also decided to go to European countries and use their system that doesn't include the 6 months or less. But we have Compassion Choices is actively working on ways that we can be more proactive and how we work with our dementia. As our population increases and the number of seniors and the number of those with dementia is only going to get greater and greater. And the amount of money it's going to take to support these patients, we've got to find better ways to be able to give them the end of life options that they want and keep them comfortable. So the more that you talk about that with your family, then the more they're going to be ensured that they are doing right by you, that they're giving, this is what mom wanted. Oh, gee, she talked about it, she wrote about it, make a little video. And it gives them that induced effort that, yes, this is what you want. Because you'll always have somebody on one side of the country that, maybe didn't hear it as often as the others have. So.
And that's, I work with a lot of people on their advanced directives, and we're always, the advanced directive is, people don't realize that the legally binding part of that advanced directive is who your healthcare advocate is. Because you can't put all scenarios in these couple pieces of pages. And so it's so important to have those discussions. And that's, when I'm working with a family, I actually have the family there talking about it. We don't even fill out the advanced directive right away. We have those discussions, those values. And that's really what you need to do with not only the people who you trust to be your advocate, but with the rest of your family.
What I did want to say is, yes, Compassionate Choices has a wonderful resource. We were talking about advanced directives and how important it is to have your healthcare advocate, someone who is going to support you. And they have great tools there that really talks about, okay, if I have any type of dementia, do you want to be treated aggressively, having all treatments, or not so aggressively, or allow a natural death? And it actually will go through the steps of, whether it's feeding tubes, surgery, infections, all the different options, and let you check it off. And then you can write your name. And so it helps to guide you along some of because we don't think of what's, like you say, some of these options that can show up, and then helping your healthcare advocate to at least have a little bit of a pathway to navigate it and what to expect and the answers to those questions that would be maybe way down the line. So definitely. And like you say, to go back to that, if there's a divorce or a death or a change in diagnosis, to go back and update it as often as you can.
Karen, thank you so much for this deeply insightful conversation and for sharing your expertise. Before we wrap up, could you please tell our audience how they can get in touch with you or learn more about the services offered by LA Patient Advocates?
Yes, we have a website, lapatientadvocates.com. The phone number is there. You can also set up an appointment there. And if you want someone to speak about medical aid and dying or all end-of-life options, or about advocacy, where you can also find the information at that place also. And also, I would also recommend going to compassionandchoices.com for excellent resources on all end-of-life options.
Great.
Finding out what's best for you.
Great. And we'll put your website in the description of this podcast. And also I'll mention Compassion and Choices in that also. So, folks, I hope this discussion has been informative and thought-provoking. If you're considering medical aid in dying, or if you have any questions about end-of-life care, please remember that resources and support are available. Thank you for joining us. If you've any questions, please comment below or reach out to me directly. And if you found this conversation to be helpful, please like, share, comment, and subscribe. This is Traci Arieli from Comforting Closure, wishing you peace and comfort in your journey. Until next time, take care.